Welcome, everyone. I'm Lori Sjogren with NAF. All right. Now it's my pleasure to welcome back our resident ataxia expert, Dr. Susan Perlman. Dr. Perlman is a clinical professor of neurology and director of the Ataxia Center at UCLA Medical Center in Los Angeles, California. Good to see you, Dr. Perlman.
Thank you so much for inviting me back. And as we've done previously, I'm going to go through the questions. And if there's a question that I don't have the answer for and feel I could look it up, I usually know where to find stuff out. Lori will remind me about those questions. I'll get back to her with the answers, and then she can get back to you all with more specific information. Prior to starting this, we were chatting about AI and how it's becoming, used so widely that, many times if you're engaging in, a meeting or something, there's a little thing you have to indicate that you will not use AI because it is, becoming more and more present. But it is dependent for its accuracy on the resources, the references it can access online. And, it still isn't going to be as sophisticated as your own ataxia neurologist. Okay, so first question is about a non-genetic ataxia. Deborah is asking, how do you distinguish MSAC from other cerebellar disorders when there's early vermis atrophy, executive dysfunction, and no levodopa response? And those are key things that make up the presentation of multiple system atrophy type C. When it presents in the first year or two, it can look like an idiopathic late onset cerebellar ataxia, but it will slowly evolve other symptoms. Parkinson's related symptoms may begin to appear, but they don't respond to levodopa. There can be changes in the autonomic nervous system, so that blood pressure will be high, it will be low, it will be unstable. There can be changes in bowel and bladder function, as well as a sleep disorder with vivid dreams, nightmares, sleep talking, moving around, acting out dreams in your sleep. Once that full presentation is there, usually by the second or third year, you can make the diagnosis clinically, and it is quite different from spinocerebellar ataxia, from the other genetic and non-genetic ataxias, because of the complexity of the symptoms that it demonstrates. There also can be changes on brain imaging early on in MSAC, where in the brainstem in the pons, there are white streaks that look like a hot cross bun sign. And although that may appear in other disorders, it tends to appear very early in the MSAs. So imaging features can definitely give you an early, sense and can help you differentiate. And it's estimated that in people with late onset cerebellar ataxia, 20 to 25% will develop these more complex features and will become diagnosed as MSA. And at least with MSA, we know that there are a number of active clinical trials going on to target the underlying mechanism. So, as complicated as it is to manage MSA, it is a pathway to get into what could be some very important clinical trials. Now, Mohammed has a question. Do I think early intervention, especially with therapies like the Arrowhead drug for Ataxin 2, could realistically delay or even prevent symptom onset if started before clinical signs appear? Yes. And this has been an aim in drug development, that you want to start, a disease modifying therapy early enough that you don't, aren't saddled with too many damaged nerves and can stabilize somebody at, a relatively mild level of symptomatology, and potentially, if you started early enough, prevent any symptoms at all from presenting. However, we could do genetic testing at birth, but do you want to start these treatments in somebody that young? Do you want to start these treatments in an 18-year-old who may have had genetic testing and they might not be expecting symptoms for another 20 years? Do you want to turn people into patients when they have 20 years to go until the symptoms might come on? So your second question, how many years prior to onset would be most effective? And the research groups that are designing clinical trials for the ataxias and also for Huntington's disease, which may have a similar mutation to with SCA, they are grappling with this question. They have a staging scale. Stage 0 is a positive gene test, but no symptoms, no biomarkers. Stage 1, positive gene test with some biomarkers beginning to show up either on brain imaging or in blood or spinal fluid that would be indicators of gene stress and early nerve cell damage. Then stage 2, there are symptoms along with the biomarkers. Stage 3, there begins to be disability. So the ideal time to start potentially is when the biomarkers begin to change, and it's anticipated that with the change in biomarkers, probably symptoms will be present in about 5 years. And that is a reasonable time to start a treatment, to continue with a treatment, and hopefully see that based on our natural history database, somebody with a gene test that's positive starting treatment could delay onset of symptoms or stabilize symptoms for a very long period of time. And this is a very exciting area of treatment development now. An anonymous person has said, I have SCA6 and my balance and speech have been bad. My doctor is no help. I tried to tell her about medicines to try like dalfampridine or troriluzole for balance and Artane for speech, but my doctor won't let me try any of them. It's possible that you may have other medical issues that would make use of those drugs problematic because of side effects. So, trying to judge why someone, might be hesitant to prescribe, a drug that they don't have a lot of experience with in somebody who may, have a more complicated medical history. So we should keep that in mind. The doctor did say that you're going to be in a wheelchair eventually. Probably true, but eventually, how many years are we talking about? Obviously not helpful. Falling all the time, and you feel like you could fall, and you keep looking for help online, and you seem to feel that you are worse than anybody else with SCA6 that you may have encountered in support groups or organizations. So, number one, don't get discouraged. You have a large group in the National Ataxia Foundation that absolutely understands SCA6 and can give you support and resources. You may want to get a second opinion from another neurologist. I presume that your doctor who's foot dragging is a neurologist who understands the disease and understands there is no cure yet, may be hesitant to try drugs that could have side effects. But I think, number one, seeking a second opinion. Number two, even going back to your original doctor and sharing the information that you have. There is published information about troriluzole. There is published information about dalfampridine. The American Academy of Neurology recognizes that dalfampridine and the old formulation of regular riluzole can be used off-label for people with ataxia. And they're available generically and they're inexpensive. And, I just learned at the recent Ataxia conference that Artane can be helpful for speech in ataxia type 6. So, I think, part of the success of some of our patients and families is being able to educate their doctors. We're all learning all the time, but don't get desperate, don't get discouraged, and don't give up. Jenna asks about the outlook on chances of a disease-modifying therapy or a potential cure being available within the next decade for someone who is currently pre-symptomatic with SCA2. I think we've seen that many of the pipelines for SCA look at drugs for SCA3, which is one of the more common SCAs. SCA1 has become involved, relatively common in certain populations. SCA2 seemed to be orphaned a little bit. There wasn't a big pipeline, but there are currently two companies that are developing disease-modifying therapies specifically for SCA2. One has already begun early stage trials, probably phase 1 trials outside the US, hopefully will come to the US within the next year or so. The timeline from the first bright idea, and working through drug design and working through animal and safety studies and then getting into human trials, that whole pipeline is about 15 years, half of which is spent preclinical, before getting into humans. So if one of the SCA2 directed therapy is already having human trials, I think it would be easy to say that within the next 5 years, we will have enough information that could get to accelerated approval if the drug is as effective as they anticipate that it will be. So I think the next 5 years, we're going to build on, the first approved drug for Friedreich's, Skyclarys. That will hopefully be a second approved drug for Friedreich's. We'll see what happens with that one. And possibly an approval of troriluzole. And from there, I think with those examples and those study designs, we'll be much more efficient at designing trials for even newer drugs for diseases like SCA2. Another anonymous person, I am 75 years old with an unspecified ataxia. In addition to balance and speech issues, I have tremors that are becoming worse. 80 milligrams of propranolol has no effect on the tremors. Usually propranolol is helpful. I am also on daily doses of amantadine and riluzole. Do I have any suggestions? So depending on how your blood pressure and pulse are doing, you could increase the dose of propranolol. And it does come as an extended release formulation. So that's one manipulation you might make. Primidone is also used for tremor. Clonazepam is also used specifically for tremor. And they can be used in small doses and maybe in combination with propranolol. And always check about drug interactions to make sure they won't have additive side effects. I don't think they will. But, I think there are things we can draw from, the tremor library. Many drugs are out there and are in use for tremor. Amantadine should have a beneficial effect on tremor. And I'm wondering if your dose of amantadine, if it's only 100 per day, you could go up to 200 to see if you could stabilize the tremor pathways that way. Riluzole may or may not have benefit for tremor. It's more helpful, I think, in general for upright stability, standing and walking. So look to increase the propranolol dose, use some of the other drugs for tremor from the tremor library. And if your amantadine dose is too low, you can increase that as well. The STEMINENT clinical trial, this is from Efrat Amram. What do I know about the STEMINENT clinical trial, and is there a way to bring it to Israel? We have an organized Machado-Joseph's disease patient community and strong connections with tertiary hospitals and are eager to take part in clinical research. And I know that, the MJD patient community is very strong there. So the STEMINENT clinical trial has been operating out of Taiwan. They did studies in Taiwan of stem cell infusions for SCA2 and SCA3. They felt they could measure benefits, symptomatic benefits, that after 3 monthly treatments, you take it once a month for 3 months, benefits continued for a year and then potentially wore off. They have also done studies in South Korea and studies in SCA6 in Japan, again, with promising results. So they are working on coming to the United States. I would contact the company about being able to set up a trial site in Israel. They're looking to branch out to more communities, more groups of patients. They will be focusing on Machado-Joseph's disease, and absolutely they would welcome your questions. The VICO clinical trial. Okay, what's the current progress and when is it expected to resume? VICO is currently operational in the Netherlands, in Europe, in the UK, and I believe they have a group in Israel. They were working through their phase 1 studies, dose finding. They are planning to come to the United States and to expand their number of international sites in the upcoming year. So I'm thinking that within the next 12 or so months, they will expand to an official phase 2 trial or a phase 2/3, where they'll continue to look at a couple of different dose levels, but also pay more attention to benefits. So yes, that will be coming down the pike and it will be expanding. So again, stay in touch with the powers that be at VICO. I have pen pals there that hear from me quite regularly, and I'm surprised they're still paying attention. But they are building their trial, and I think we can all be encouraged by that. Another anonymous question: typically, how large is the window between the pre-symptomatic phase and the point at which irreversible neurodegeneration begins? And this is somebody referencing 39 CAG repeats for SCA2. Now, we've already commented that there are biomarkers for most of the SCAs that are produced by the mutant gene, can be measured at some point to begin showing changes even before there's symptoms. And the general feeling is that from the first biomarker changes in blood or spinal fluid or imaging, you've got 5 years until symptoms begin to appear. Now, you can have symptoms without irreversible neurodegeneration. The nerves can be dysfunctional, but they're all still there. So I think, permanent neurodegeneration, where, you've lost groups of nerves that are never going to come back, could be another 5 years. So the debate, how soon do you want to begin treatment? Do you start when the biomarkers are changing? Do you wait until there's actually some signs of nerve cell death, or somewhere in between? So this is another anonymous note from Alfred Tan. It's 2 a.m. where he is. I'm glad he's still awake. Regarding the woman that was born without a cerebellum, but it took her 24 years to seek medical attention, what do I think? This is something that I probably haven't seen, but I know that there are reports of people born with very small cerebellums or atrophic cerebellums that never developed properly. And with the developing brain, if a part of the brain is limited by some genetic or other factor, often there are parallel pathways that will take over, so that somebody can have an extremely small cerebellum, have no signs of ataxia. They were delayed in learning to walk, but no signs of ataxia until something changes, potentially, say, 24 years. And then somebody does an imaging study and they say, oh my gosh, you have a small cerebellum. So it is reported brain development in infancy and childhood is very important. And certainly brain aging in the latter part of our lives also is very important at maintaining performance. Since the majority of us are struggling with a partial cerebellar loss, while somebody else is going strong with no cerebellum, they probably have compensatory pathways that have been activated. There could be other genetic pathways responding to, altered cerebellar electrical activity that are, adding to the compensatory strategies. It was out on PubMed. I'm going to look this up, and Lori will remind me to look this up. And found, several other cases of people born without a cerebellum or with a very small cerebellum. And yes, the brain is very resilient. Look at people recovering from stroke miraculously, going from a severe disability to being, almost normal in the best circumstance. So regarding the study by Dr. Scott Barbuto regarding BDNF, by separating test volunteers into balance and aerobic group, found a mild growth of their cerebellum. And I'm going to have to look that study up also, although the growth is not very prominent, but it does sound hopeful. And I will look that up. I'll look up both points 1 and 2 that you have brought up. Point 3, neuroplasticity is a big word with us suffering a neural condition. But what that means is that brain cells, although we're born with basically all the brain cells we're going to have, we do have some small immature stem cells embedded in our brain that stay dormant for a long period of time. Neuroplasticity, is what allows the brain to heal after a stroke. it is a mechanism that could activate some of those nascent stem cells that might be in there. So it is believed that after passing a certain age, the brain stops growth and begins to deteriorate. And that's usually sometime in our 30s. It starts on that downhill course, but we have an enormous amount of reserve. So with normal brain aging, people can get to age 80 with essentially no change in brain-related functions. I mean, their muscles may not be quite as pliable and strong as when they were in their 20s, but the brain itself has enough reserve to carry on until the age of 80. And this is research that was done at the VA hospitals in the aging veteran population. So, good set of questions about brain reserve. And Lori will remind me about your first 2 points that I'm going to have to look up. And I apologize for that, but I'm learning right along with you. So another anonymous question. Is there any update on when troriluzole might be available? So it has been pushed off for its final determination with the FDA until August, I think. We thought we'd have more information by now, but it's going to be a little delayed. Let me go back there. Hang on. When it might be released to all SCA patients for compassionate use. So the compassionate access is active now, even while we're waiting for the FDA to approve it officially as a prescription drug. So you can go through your ataxia doctor who can, make a registration number and apply to get a compassionate source of the drug for you to try individually. And there's very few requirements, some safety testing of blood before starting and some regular monitoring. But this is something you could seek out with any of the SCAs. And we're up to SCA 51, I think. So anybody with a genetically demonstrated SCA of any of them, could access the compassionate program. Danielle is asking, do we know which vitamins are good for the brain? B vitamins are known to be good for the nervous system. Vitamin E is an important anti-aging, antioxidant vitamin, which is good for the brain. And then there are other supplements that, like omega fish oil, I think has a track record of success as well. So if you were looking at, some appropriate vitamins that we know the brain depends on, the B vitamins, vitamin E, and omega fish oil, I think are reasonable choices. There are many other vitamins out there, vitamin D, vitamin A, and a series of others, but those are the ones that I think have the most literature. And if you're planning to start a vitamin regimen, clear it with your primary doctor. If you're on medication, some vitamins may interact with certain medications. You want to make sure you're not undermining something else. Mary Ellen, could I explain why dalfampridine can be helpful in those with ataxia? Dalfampridine, in its generic compounded formulation as 4-aminopyridine, has been around essentially as long as I've been in practice. It was known decades ago to be helpful for spinal cord injury, that it could improve the electrical transmission along spinal nerves if they had been damaged and weren't conducting properly. And I think it was also found to be helpful for dizziness and vestibular inner ear connected pathways. And ultimately, it was found to be helpful for episodic ataxia and ataxia in general. So it was kind of a learning curve over many years. It was finally approved in a prescription formulation, Ampera, for multiple sclerosis, for gait, to smooth out spastic gait and probably to improve balance in gait. Accessing it when it was still a branded drug was difficult if you didn't have MS. Now it's available generically and with a coupon service or through the Mark Cuban or other online, pharmacy services. You can get a month's supply for under $30 per month. So, I think it is reasonable to try. It's, probably going to be more helpful for people with episodic ataxia, but it could stabilize, regular ataxia. It may help more with the dizziness that's a disequilibrium that some people get. And people with upper motor neuron features that complicate their ataxia spasticity could also benefit from this. And you can still get it compounded if the prescription formulation, which is a 10 milligram capsule, is too strong. A compounding pharmacist can mix it up. And I think the person that I was able to get on it, slowly over a long period of time, started with 2 milligram capsules. Another anonymous question: how can CRISPR and other gene editing techniques be useful in treating SCAs? Okay, so CRISPR directed towards the mutation in a spinocerebellar ataxia could be designed to target that mutation and snip it out, rejoining the DNA so that you have a strand that's a normal strand with the mutation snipped out. And you can see by the hand waving, this is, very complex science that I'm not an expert in, but there are companies that are working on CRISPR-related technology specifically for spinocerebellar ataxia. They are not in human trials yet, but they will be moving forward. This is comparable to some of the other technologies that are in clinical trials using an antisense oligonucleotide, a small piece of the same type of DNA RNA material to attach to the mutation and target that mutated segment for destruction before it can make protein. Then the protein is not there to make damage. So there's been a lot of ways to try to cover up the mutation, modify what the mutation can do, or snip out the mutation altogether. We hope to see progress in all of these technologies over the next 5 years. My sister wants to know, how unusual is it that all 3 siblings carry the gene to SCA3? There are no other brothers or sisters. So for a dominant disease where you have a parent with one bad gene, copy of the gene that is enough to cause symptoms, the other copy of their gene is normal. And when they're having children, they'll pass on either the mutant gene or the normal gene. And you figure the odds, if you're, flipping coins, is 50-50. So you'd expect, maybe half of the children to have the bad gene and half to not have the bad gene, to have the good gene. But, I have seen families where every child of the particular affected ataxia person has the bad gene. And I've seen families where no one inherited the bad gene. So I think there are things in the transmission of DNA that may modify, when a bad gene is selectively transmitted or when it might be selectively not transmitted. So it is seen. I think if you looked at, large numbers of families, with hundreds of at-risk individuals, it would end up to be more 50-50. There's strength in those numbers in showing statistically what we think should be happening. But in smaller families, you're right, you could be flipping that coin and it comes up heads or tails every time. Does the weather, high heat, affect symptoms more? Yes. Cold weather also can, make muscles stiffer and can amplify the symptoms of ataxia. And some people don't tolerate the heat that well. So, temperate climates, keeping, the temperature in your home at a comfortable level will usually avoid flaring up your symptoms from either too hot or too cold. And if you find that you are heat sensitive, it's important to check your thyroid. Make sure that your thyroid activity is in the normal range. Another anonymous question: how do you see AI or computational biology accelerating drug discovery or biomarker identification for SCA2? So AI in general, seems to be, at least the way I've been using it, a sophisticated search engine that can go through, dozens and dozens of postings on the internet, pull out information and organize it in a way that flows. So, I recently searched, AI for, information about a particular disease, not an ataxic disease. And it came out with a list of things to monitor and a list of things that we're looking at in research. that it would have taken me probably an hour to pull out myself, and they pulled it out in just a few minutes. So simple use of AI like that is, using information that's already there. Now, being able to use AI or computational biology to, accelerate drug discovery, find new things, find biomarkers, is used more in the lab, in the scientific realm, where you're taking raw data and processing it in more rapid and complex ways to look for trends in biomarkers or trends in drug design that might be worth looking into further, as your next step in the lab. Kim has a question, was wondering if there was an update on Vico. We've already talked about Vico and also Steminent. So I think we can hopefully hear more from both companies as this year goes on. How are autonomic functions affected in SCA4, specifically blood pressure and gastrointestinal issues? Now, SCA4 has peripheral nerve involvement, as I remember. Peripheral nerves are involved in regulating muscle and in regulating involuntary muscle, which are the small muscles that control our GI tract and control arteries, where blood pressure is generated. So if you have a genetic ataxia where the peripheral nervous system is involved, and that includes the autonomic nervous system, you will notice changes in circulation, a tendency for the feet to get puffy, to get cold, to get bluish. Blood pressure, could, drop a little bit, as we see with other autonomic disorders. And the GI tract, once you get below the esophagus, is run by involuntary muscle, which is supplied by the autonomic peripheral nerves. And it can cause, slowing of gastric emptying, slowing of the bowels in general, and also slowing of the bladder. So, I think that's probably what is behind what's going on in SCA4, as I remember. And Lori will, mention, to me later on that I should double check that and make sure I haven't said anything wrong. Again, a lot of interesting questions coming out about the Arrowhead Ataxin 2 drug development, and, where they're going. And they have a question, is this similar to how Atlas is being used for ALS? Well, I don't know about Atlas for ALS, but again, Lori is going to, remind me to look that up. But certainly most of the gene blockers, drugs, like the Arrowhead drug, are looking at early stage patients and ultimately will be able to work with pre-symptomatic individuals on the basis of biomarkers being used as a guide. Otherwise, if you started with somebody at birth who had no biomarker changes and no symptoms and you put them on a treatment, how would you know it was working? Another anonymous question, can adeno-associated virus and or platform vector gene therapy be used to treat inherited SCAs? Yes. This is the, certainly the AAV approach, and I'm not so sure about the platform vector gene therapy. Lori, have me look that up. But AAV uses a viral envelope to put into the system, into the brain, into the spinal fluid, spinal pathways that supply the nervous system. Usually in the ataxias, it's used to put in an artificial gene that will then make a blocking RNA that will block the mutant gene from making the bad protein. So rather than getting spinal taps every 2 or 3 months, they can do a one and done AAV infusion carrying an artificial gene in that will make the blocking chemical constantly to constantly block the bad protein that your mutant gene is making. And it is something that is, being explored now in Huntington's disease and certainly could be used in the inherited ataxias that have triplet repeats, as Huntington's does, but could possibly, be used for one and done approaches in other types of mutations. Another anonymous question, as SCA is a rare disease, is there much research happening? And will we continue to see an increase in research for this disease? Absolutely. If you look at the growth in literature from before, when the genes were being discovered in the 1990s, And now since the 1990s, when we began to find, the common genes and even rarer genes are still being uncovered, there's been an exponential increase in research publications showing the interest that is now happening in basic science and also in translational and clinical science. So I think, there is, research going on now in drug trials, as we've been discussing, and there will be even more in the future. Anonymous attendee, do I know any new drugs or treatments for nystagmus? Nystagmus is tough to treat. I think the greatest success I have had is with somebody with Arnold Chiari, where they had compression of the cerebellar pathways by the bones of the skull. The skull didn't develop properly and it was tight, and the cerebellum was being pressed and tight, and they had surgery to open that area up, but had nystagmus. Baclofen, very successful for nystagmus from that process. But there are half a dozen different types of nystagmus. I know that for patients with Friedreich's ataxia who don't have technical nystagmus, they have some other, involuntary movements of the eyes, that Skyclarys seems to suppress it. I know that for patients with 27B who are taking dalfampridine, that may suppress the nystagmus that they have. And there's a long list of drugs, which I believe are on the National Ataxia Foundation website, that have been used or popularized for treating nystagmus. But because of the number of different pathways in different ataxias that can trigger nystagmus, the same drug may not work in all situations. William is asking, is MS a form of ataxia? How can you tell the difference between the two? If we're referring to MS, multiple sclerosis, that is an immune-mediated disease where your body is making antibodies that target the coverings of the nerves, making them scar up and not transmit the electrical signal properly. But they can have symptoms of ataxia or spasticity or weakness or nystagmus. Any of the symptoms you would see in the genetic ataxias could be seen in multiple sclerosis, but from a different cause. And in that case, it's very specifically a set of bad antibodies targeting the nerve pathways, scarring them so they don't conduct properly. You can pretty easily tell the difference by the pattern of disease. Classic multiple sclerosis has attacks of symptoms, and then they resolve, and then another attack of symptoms, and they resolve. But you're saying episodic ataxia can do the same. So, the best way to differentiate is with MRI imaging. There are very specific MRI signals in multiple sclerosis that show the scarring that's going on from the inflammation from the bad antibodies. That type of scarring is not seen in the majority of the genetic ataxias. However, the symptoms, could be, very hard to distinguish just on the basis of an exam. Serena has a question. Can you address autoimmune ataxia? So as an extension from our discussion of multiple sclerosis, the autoimmune ataxias are a group of cerebellar ataxias where the target is the cerebellum. Bad antibodies are being produced from a variety of different causes that can target the cerebellum specifically, damaging the nerves, not just the coverings of the nerves, but the nerves themselves, so that they don't operate properly and you develop symptoms of ataxia. So one of the common autoimmune ataxias is GAD ataxia, GAD, which is also associated with stiff person syndrome. So that, with GAD-mediated ataxia, you can measure the GAD antibodies in the blood. They will be elevated. You may have symptoms of spasticity or stiffness. You may just have a simple ataxia, and it is usually very effectively treated with, anything that will block or suppress that immune response. And there are a variety of agents that are used. Again, I think there's a discussion on the National Ataxia Foundation website. If your autoimmune ataxia is being triggered by an underlying hidden cancer, which can trigger the immune system to begin making antibodies that are behaving badly, as it were. Then there's obviously a need to search for the hidden cancer. So anybody who has developed a subacute ataxia where it seems to come on fairly rapidly, more rapidly than a genetic ataxia, which tends to be very slow when it comes on. Part of the workup is going to be, looking at vitamin levels, poisons, toxins, and looking for bad antibodies. If these bad antibodies are found, usually the next step is to do imaging of the chest, of the abdomen, to look for a small hidden cancer that could be triggering the production of bad antibodies. And then you treat the cancer, antibody production goes away, and you've stabilized, if not cured, that problem. But you do have to catch it early, before there is significant damage that may not be reversible. And then Joe has a question: can we obtain early access to troriluzole through your office? So doctors who are prescribing troriluzole could be any neurologist or any physician for that matter, going through the expanded access program, but they do have to see you in person. So you need at least one in-person visit to start the process. So, I have seen, a number of patients. I have a number of patients who are able to get the expanded access troriluzole, but it does start with at least one in-person visit. Nuno Gallego, does dalfampridine work in SCA3? Yes, it might. My doctor says it won't. Won't do anything for balance and coordination. It can. I do have SCA3 patients who are taking it. It can help with tremor. It can help with nystagmus. It may help with balance and coordination. There may be no response at all, and you won't really know until you try it, and you need to be on it for at least a month to determine if it's helping or not. Another anonymous person: I've had hereditary ataxia for over 30 years. 3 months ago, I was diagnosed with myositis. Is this related? Regular myositis, an inflammation of muscle, often triggered by the immune system, is not known to be related to the genetic ataxias. And I think these autoimmune ataxias and autoimmune myositis or inflammatory myositis, typically come on in our later years. So I think the distance in time between your ataxia and your myositis suggests that they are not directly related. Ruth says, I've been diagnosed with episodic ataxia type 2. The disorder has progressed to the point where I now have dystonia and Parkinsonism. So other parts of the nervous system have become involved. My brain MRI indicates no substantial change in the cerebellum since you were initially diagnosed in the year 2000. So it looks like your cerebellum was targeted first, and then as the disease progressed, with the genetic stressor from that mutation, you began to notice changes in the basal ganglia. So you're taking 1,000 milligrams of acetazolamide for treatment of the episodic ataxia, which has been a first choice for many years to stabilize the episodes of ataxia, but it is no longer sufficient for controlling ataxia symptoms. Ampira, dalfampridine ER, did not work for me and made my balance worse. Why do my episodic ataxia symptoms continue to worsen if there is no change in the cerebellum, and can the progression be slowed down? So the cerebellum communicates with other parts of the brain. It sends signals up to the basal ganglia, where the Parkinsonism and dystonia are coming from. It receives signals from the upper brain that passes through the basal ganglia. So there's a lot of communication with other parts of the brain that, as the disease worsens, as the cerebellum worsens and is sending out fewer signals, other parts of the brain can begin to malfunction as well. The cerebellum, it sounds like you've lost a percentage of it. And it would be unlikely that a degenerative process like a genetic ataxia would completely wipe out the cerebellum. There's going to be nerves in the cerebellum, that, are stronger and more resistant. But it sounds like you've lost a significant amount and you've kind of reached that plateau or ceiling, where you're probably not going to lose more of the cerebellum, but you will be compromising its connecting pathways, so that they will add to the problem. And the big question is, can the progression be slowed down? So when we think about neuroprotection and slowing progression of neurodegenerative disorders, either genetic or non-genetic, we think about vitamin E, we think about coenzyme Q10, we think about omega fish oil, all the anti-aging hype that's on the internet, can be interpreted to slow progression of brain aging and prop up, pathways that could be contributing to brain, inflammation or damage to nerve cells. So I'm not saying that going on vitamin E, CoQ10, or omega fish oil is going to slow progression, but the one drug that seems to slow progression, troriluzole, we've been talking about, but regular riluzole, the older formulation of troriluzole, was demonstrated in a European study to slow progression. And I'm thinking, it might be worth trying riluzole, regular riluzole, just to see if, you can stabilize, and even have a little improvement, over the next 3 to 6 months. I mean, that would be the thing I would do if you were my patient. Um, the fact that the extended release Ampera did not work, it's possible that the immediate release formulation, the compounded formulation that a compounding pharmacist can mix up for you, 5 milligram compounded capsules that you could take 3 times per day, might work better than the extended release. So those are two possible pathways you can pursue to try to stabilize your episodic ataxia again. Then another anonymous question: what supplements, lifestyle interventions, or medications would I recommend discussing with my neurologist that may help delay onset or protect neurons in the pre-symptomatic stage? Good exercise, physical conditioning always helps. In the animal studies, it's known to stimulate nerve growth factors, which can protect nerve connectivity. So that's one thing you can do if you are pre-symptomatic. And it's probably the thing that is most reliably helpful, is getting in a good exercise program that includes cardio. In the animal studies, the mice that were able to be on their exercise wheel as opposed to the couch potato mice did much better. And that's probably, easier to integrate into your, daily life, and safer regarding side effects, unless you injure yourself, which hopefully you won't do, as opposed to committing to a vitamin regimen or other medications. There are anti-aging vitamins that could potentially be helpful. That's never been proven, and that's vitamin E, CoQ10, and the omega fish oils. If you wanted to look for, a supplement that could enhance what your exercise is already doing. Okay, Maryanka, are there possible dangers of prolonged infusions of Rituxan? Now, Rituxan is used to suppress the T cell immune system that, the B cells that make antibodies. The T cells are spared. So as opposed to regular chemotherapy, which suppresses B and T cells. And so you end up with an immune deficiency. Rituxan is very specific just for the B cells and the B lymphocytes, so that your T cells should be still present in good numbers to fight infection. Prolonged infusions of Rituxan, I mean, I've had patients, if you've had 15 infusions, depending on how frequently you're getting them, it could be going on for several years here. I've had patients getting Rituxan for 3 years, and so far they've done well. Their T lymphocytes are hanging in there, the B cells are suppressed, the bad antibody that this is targeting is suppressed, better than it was with any other approaches. So if you are getting repeated infusions of Rituxan, definitely check it out with, a hematology oncology person who would use this, for, lymphoma, for, various other neoplastic disorders, and would use it consistently over a long period of time. And again, we could look up, potential long-term side effects in the literature. I'm sure it's there, but at least it's less risky for your immune system than taking a general immunosuppressant, which will knock down the bad antibodies that we presume are being produced, but will also knock down the T cells. Can Dr. Perlman give an update on the FDA's approval of troriluzole? We're waiting to hear sometime by August. We're anticipating we'll hear something. Annie, newly diagnosed with SCA2, doesn't know how fast progression or slow progression feels. I feel like things are changing quickly, yet I don't know what to expect. Annie, if you are younger than 40 with your first symptom onset, the typical progression from when you first notice symptoms till they might be causing a disability, harder to do things, having to give things up, is typically about 5 years. If your first symptom onset was over the age of 40, a later onset form of SCA2, it would progress much more slowly, similar to SCA6, which typically comes on after the age of 40 and progresses very slowly. So you have to look at, what is progressing. Is it your gait imbalance, instability? Is it just because of the ataxia, or do you have some stiffness or tightness in the neuromuscular pathways that could be contributing and would be treated a different way than the ataxia? Are you exercising? A good exercise program can definitely slow progression and protect, performance on a day-to-day basis. So, it's important, when, to have visits with your neurologist at least every 6 months. And some people will see them every 3 months just to track things that they feel are changing rapidly. Sumner, how go about genetic testing? A family member has been diagnosed with SCA27B. And if you are at risk, you can have your local doctor or a genetics consultant order specific genetic testing for SCA27B. And since you know that that's the gene in your family, and that will turn around and let you know with, whether you have that mutation or not. Now, the National Ataxia Foundation has had a free genetic testing program for certain SCAs, and I don't know if it includes SCA27B, because they are trying to track in families at-risk persons who may not have access to genetic testing because their insurance refuses to pay for it. And so there has been a free genetic testing program through the National Ataxia Foundation that I would inquire about. But, the single gene test is available. There's 1 or maybe 2 labs in the country that do it. One is the University of Chicago, and the other, I'm not sure if they've, finished their, the development of that test yet, but it is available commercially. And then Georgia says ataxia of the cerebellum has not been diagnosed. I'm just assuming this is the ataxia that your child has, where cerebellar atrophy was found on brain MRI since age 2. So do we know if your child was born with a small cerebellum and will grow into it, such that, and I've had families where there's a genetic cause for a small cerebellum, and sometimes the delays in standing and walking, wobbliness are seen early on, but potentially they grow into it by activating other pathways that can take over from the cerebellar pathways that are diminished. And so it'd be important to know if in the family anybody else has been born with a small cerebellum. On the other hand, perhaps it was acquired. Maybe there was an infection or some damage that occurred at birth or in early life that has caused this stunting of the cerebellum. Again, same symptoms, delayed milestones, never standing or walking, and the wobbliness that you've noticed. So, the question is this going to be progressive? Will, all, motor function be eventually lost? There are some genetic ataxias that can present in infancy and early childhood, and I hope that your child has been screened for these. There is, at least one or two genetic factors that can cause people to be born with a small cerebellum, which typically doesn't progress, and people grow into it and they do well in later life. So deciding between a genetic cause that is stable and could improve versus a genetic cause that is expected to get worse, is a question that could be answered with proper genetic testing. And losing head control, is part of the axial, the upright stability pathways that, control standing, control walking, control trunk and head stability. So, I think, I hope that your child is seeing a physical therapist and is working with rehabilitation specialists to, make up, for, some of the motor problems he's experiencing. Then I think we have time for at least one more question. Jeff has a question. Have you ever tried a combination of exosomes with stem cells administered via intrathecal? No. However, stem cells can be usually given by infusion. They're not typically given intrathecally in the studies that I'm familiar with, although, there's a study in non-genetic ataxia that was giving it by spinal injection. But in, certainly the STEMINENT group is by infusion into the vein. Exosomes are of great interest because they're little nanoparticles that can carry, drugs, can carry, other, important, nerve growth factors, et cetera. And can also be markers of how the brain is doing. If there's a buildup of, abnormal things in the exosome. So this is, very new technology that is under intensive research. Okay, I think we're at the top of the hour, and hopefully you've been keeping
Correct.
track.
Yes. Great questions again today. Thank you so much, Dr. Perlman, and for everybody for all the great questions that you guys have asked. I have kept track for you, Dr. Perlman, all those things that you wanted to go back and look up. And for those that want to refer back to this session, it is being recorded and the recording will be available on NAF's YouTube channel and NAF's website. And for all those that we didn't get to your questions, please join us for the next session and ask your questions again. And we look forward to seeing many of you on our next Ask the Expert session. Thanks again, Dr. Perlman, and thanks
Thank you.
everyone.